Good afternoon, everyone. On behalf of Mahiyanganaya Clinical Society, I would like to welcome you all to the 15 sessions of our academic hour for continuing professional development program. So the lecture series is proudly conducted by the Clinical Society of Mahiyanganaya in collaboration with the Government Branch Offices, Government Medical Officers Branch Union Association. So far we have had many successful sessions, and your active participation and commitment have been the key behind these successful events. And today we have another valuable opportunity to broaden our knowledge on another pivotal subject, the essentials in oxygen therapy, a subject that spans across all fields of medicine, making it vital for patient care. And we are truly honored to have with us Dr. Punhasi Waduge, the consultant anesthetist of BH Mahiyanganaya, who will be sharing her expertise with us on the topic. So without further delay, I would like to introduce our speaker formally to Dr. Prabhash Hathurusingha to take this stage. Sir, the stage is yours.
Good evening, everybody. Welcome you all for the 15th academic cover program of Mahiyanganaya Clinical Society. I think we have, as our announcer said, that we have been conducting this since January this year, successful 15 program this is. So today our lecture will be essentials in oxygen therapy. Will be done by Dr. Punhasi Waduge, consultant anesthetics, base hospital Mahiyanganaya. So Dr. Waduge graduated from University of Ruhuna MBBS in 2012 and MD Colombo anesthesia in 2020. I think she had an excellent undergraduate and postgraduate records. She has a gold medalist in final MBBS and gold medalist in both MD Part 1 and Part 2 examination. So we are very lucky to have her in our hospital. And she worked as an acting consultant anesthetics before Mahiyanganaya Hospital as in Balapitiya and as well as in Kaathankudi hospitals. So she had her foreign training in UK at Luton and Dunstable Hospital, and after that she is currently working as here consultant anesthetics in base hospital Mahiyanganaya. Very much important topics in every aspects, every speciality. So thank you for choosing this topic and accept the invitation from Clinical Society of Mahiyanganaya. So as a physician, I still remember one sentence regarding oxygen. As during our medical student time, always what we were told was always think oxygen as a drug. So we hardly think it is a kind of a drug. So oxygen is always a drug. It has a dose, duration and termination. So that's what I remember very much in my career regarding oxygen therapy still. So over to you, Dr. Punhasi. Thank you.
Thank you very much for the kind introduction, Dr. Prabhash. Good afternoon. And also thank you for the Clinical Society and the GMOA in Mahiyanganaya Hospital for this opportunity given. So I chose this topic, essentials in oxygen therapy, because I believe that it is an important and day-to-day use in oxygen by almost everybody here. So this presentation, the objectives I'm going to discuss regarding how oxygen delivered to tissues. When you breathe in, how it delivers to the tissues. And then when there's hypoxia, that means if you need to increase the saturation or the partial pressure of oxygen, how would you deliver oxygen extra through different delivery systems? And if you need to give high amount of oxygen, like higher fraction of oxygen, more than 60%, and also, as we all know, as it's a drug, we need to rationalize our use, so it has to be prescribed with the dose, duration, and tailing off when it is not necessary, because hyperoxia is also harmful as much as hypoxia. Right. How to do this? Okay. Sorry. So oxygen is most common drug we use. In humans, because everybody are oxygen dependent, however, at the cellular level, the oxygen levels are very minimal. For example, you breathe about 100 millimeter mercury in the blood when you breathe oxygen, but at the tissue level, it's very low as 5 millimeter. So in the cellular level, though we give oxygen, the cells survive in a very restricted oxygen environment. So this is much as enough to survive. However, if it is lesser than that, so there will be less oxygen and lesser ATP production and cells will die. At the same time, if it is more than that, what will happen, as this curve shows, sorry, it's not moving, the hyperoxia, there would be more oxygen, more byproducts like reactive oxygen species, which I'm going to discuss later. So that will cause direct tissue damage. That's why both too little and too much oxygen is harmful. So this is how oxygen delivered to tissues in generally. So you breathe in air or oxygen. The fraction of oxygen you inspired matters, and how much you take into the lungs matter, which depends on the respiratory mechanics. That is the breathe-in frequency and the tidal volume, which is basically the minute ventilation. So any of this, when it is lower, the oxygen delivered to the lungs will be lesser. So once it's entered the lung, it has to go into the blood, that is through the pulmonary capillary membrane, the permeability which is matter. And then when it enters the blood, majority of oxygen will bind in with the hemoglobin, and then the lesser amount, though it is less, it's very important, will be dissolved in the plasma. So in the blood vessels, the oxygen content depends on how much oxygen available as bind to hemoglobin, which depends on the amount of hemoglobin always, and the ability to bind, the capacity, and the dissolved oxygen fraction. So when it is in the pulmonary vessels, oxygenated blood, these has to now deliver into the tissues. So this is where the cardiac output plays a major role. The oxygen has to deliver into tissues. So you have to have good cardiac output with good heart rate and stroke volume and good peripheral circulation to deliver it to the tissues. Then only it will be delivered at the tissue level, and the same mechanism, according to the gradient of the pressure, oxygen will be taken to the cells. So therefore, the oxygen delivery, obviously, when it's in the blood, depends on the saturation of the hemoglobin and the oxygen binding capacity and the amount of dissolved oxygen and the hemoglobin concentration. When it is there, it needs good cardiac output to deliver it to the tissues. So it's only one component, that the saturation and the partial pressure. When you optimize that, if you still have hypoxia, the features like increased lactate, you need to think whether your cardiac output is enough or your hemoglobin is enough, because if it is low, even with a saturation of 90, with a hemoglobin of 60, you are not delivering adequate amount of oxygen to the tissues. Right. So hereafter, we will discuss about how the saturation and the partial pressure, that the oxygen content to given extra oxygen can be increased. Right. So just concentrate on this, the below diagram. So when a patient breathes, suppose that somebody breathes about 500 ml of tidal volume, what happened? Initially there would be a gradual rise in the peak, the pressures, the flows you take, it goes like a, sorry, I can't show. Oh, good, thank you. So initially they would increase the flow and then gradually down. Through this time period with the variable flow, you get about your tidal, the 500 ml of tidal volume inside. But with this time, if you look at, the flow always change. So the usually healthy adult at normal breathing levels, it's like 40-30 liters per minute of peak inspiratory flow. This is how normally person would take breaths. If the patient is dyspneic or the patient have increased respiratory work of breathing, the patient will have very higher, maybe taking very higher flows and lesser time to have the same tidal volume or lesser than that. So the patient's peak inspiratory flow will be more than that, like it may be even 80 or even 100. Or, for example, like in acidotic patients, might take very high flow and also take a little bit more time. So this all depends on how the patient breathes in a dyspneic situation. Now think that if you give about 10 liters or 5 liters of oxygen continuously, so up to this level, so think that there's a line here, so you will deliver about 10 liters of oxygen. So after these 10 liters, when the patient is breathing above that in the peak flows, the patient will have mixed oxygen from the 10 liters and from the surrounding, right? So the amount of oxygen depends on how you take from how much you take from outside and how much you deliver. It's mixed. So if you need to give 100% oxygen, at least you need to increase the flow to match the peak inspiratory flow. If you give like 40 liters continuously, for all the time, the patient will have 100% oxygen, 14 liters, depending on the patient. Did you understand what I said? Right? Anybody didn't understand? No. So, suppose if a person needs to have 100% oxygen all the time, either you need to increase the flow to match the peak inspiratory flow. If you match the peak inspiratory flow, throughout the cycle you will have 100% oxygen, right? Or else, that's the basics of high flow nasal cannula. Or else, what you need to do is to have a reservoir filled with the volume more than the tidal volume, so the extra oxygen you needed will be taken from the reservoir. So still you can have 100% oxygen without a higher flow. That is the basis of non-rebreathing mask. So if you want to give high amount of oxygen, you need to either provide a good peak flow to match the patient, or else you have to have a good reservoir to match the tidal volume. Right. So then we'll move, friend, this is a very low. You can give up to 4 liters per minute of flow, or it doesn't match the peak flow. And you can't increase higher pressure, and whatever the flow you give, if you give dry air, simple device therefore, but if you give 4 liters, it will generally in a normal breathing pace, you may exhale, there would be a pause. Exhale, there would be a pause before the next breath. When you are not breathing, you can in with the next breath. Volume, and the volume you pause, it's all depend on how much you take, how many you have. So that's why these are variable performance devices. In general, but if you have rough idea, if you give 1 liter, it will be like 24% of oxygen. If you give 4 liters, it's generally like 35% of oxygen. So this is a good device, simple device, freely available and not claustrophobic, good for claustrophobic patients. But it's only good if you, in case if you need to give more, then you have to move to something else. So how this works, this mask, it is also acting as a small reservoir, which is around 100 to 200 mils of volume. So what happens, you deliver about 5 liters of oxygen through this port, and there would be more oxygen mixing with the exhaled air and the reservoir, and with the next breath, the patient will inhale more oxygen-enriched air. The peak flow, the patient needs to breathe from outside from here. The fraction of inspired oxygen always now depends on the oxygen input and the volume of the mouth and the amount of air you take depending on the patient's breathing pattern. So now you might think whether we can increase the size of the mask to increase the reservoir. That's not an option, because what happens if you have a large reservoir like this in a mask, the exhaled carbon dioxide will go and entrapped. If your flow is not good enough, there will be more carbon dioxide left for the next breath. So you will be breathing carbon dioxide, that is called rebreathing, right? And that same happens if your flows are very low. So you can't use normal face mask, the Hudson mask, with very low flows like 1 or 2 liters of oxygen, remember. If you use like that, you're going to rebreathe. The same thing happen. You have to give at least 5 liters of oxygen through the mask. So then only this pressure and the volume will push out your carbon dioxide from the exhaled air. So then only you will have oxygen enriched air without rebreathing. Right. These are all variable, but in general, if you give about 10 liters of oxygen through the Hudson mask, you will have about 60% of oxygen. And if you give at least 5 to 6 liters, you will have around 40% of oxygen. Now, if you want to give more than 60% of oxygen, just consider about the delivery of oxygen, you have to use either non-rebreathing mask or high-flow nasal cannula in the ward setup. So the non-rebreathing mask, it uses the reservoir, that's how it works. So if you go and see, you will have a valve here, which is a flip valve, only allowing exhale air from the mask to outside. So what happens, if you put 15 or 12 liters of oxygen through the mask, it will enter here, it will go to the face mask, but at the same time, it will fill this reservoir, which is more than the tidal volume. So when you start initially, you need to fill this bag, so there will be adequate amount to compensate your peak flow. And then when you breathe in, you will take oxygen through this small amount left in the mask, and the flow, and the peak flow will be compensated or taken out from this reservoir. So you will have nearly 90% of oxygen, but that all depends on your leak. Because if this is not a very tight fitted mask, so there's always a leak around. That's why it is not giving 100% oxygen. But if the leak is minimal, the amount of oxygen you get would be 90% or more than, definitely more than 70%. But when you use this, you have to make sure your reservoir bag is not empty. So if it is empty, that means you will not have oxygen, 100% oxygen taken up from the reservoir. It's already empty. So the patient will take from outside. So that's how you would understand the patient's breathing. If the patient is breathing with a higher flow rate, you might need to increase the flow up to 15 liters and see whether your bag has some volume at all the time. But then with just observing, you can come down with the flow, making sure that you have some amount of oxygen even after the expiration in the reservoir bag. So it's not completely empty and you're not going to dilute air with your oxygen. So that's how you would have nearly 90%, 100% oxygen through the non-rebreathing mask. This is very cheap, always available in the wards, and cost effective. You just need to give 15 liters of oxygen with the bag reservoir, but you can still achieve 90% above such FiO2. However, this does not give any additional advantage like PEEP or a pressure to prevent collapse of the lung. So this is the other device which we can use, and this was very famous during the COVID time. The high flow cannula, this uses the other principle. It increases the flow, so it gives a continuous flow to match the patient's peak inspiratory flow. The patient will take that amount of flow, so all the time the fixed amount of oxygen can be taken in. So whatever the amount you need, if you need to give 100% oxygen, you can match the patient's inspiratory flow and deliver 100% oxygen, or 50%, whatever you need. But if you look at it, it has only peak flow around 60 liters per minute. The delivery is maximum 60 liters per minute. What if the patient is severely dyspneic and you have to provide oxygen unless the patient is intubation and CPAP? So if the patient is breathing very deeply and the peak flows are like 80 liters per minute, you can't achieve higher amount of oxygen through this device. Addition to giving reasonably fixed FiO2, the fraction of oxygen, because of the higher flow, it will add a PEEP effect, that is the positive pressure effect to the nasal cavity. So that will be helpful to prevent atelectasis in the lung to a reasonable extent. But it's not a device which can use instead of NIV or intubation, because the PEEP effect, which is delivered through the high flow is minimal, like 5 millimeter mercury, centimeter water. So that PEEP is not sometimes enough. It's a very small PEEP. And also, if the patient is breathing from the mouth open, so that PEEP is going to lose. So the patient needs to have closed mouth with a very good fitted nasal cannula to have that PEEP effect. As I told you earlier, if you are using higher flows, it can dry your airway. So this large tubing accommodates the high flow. And also this is humidified and warm, therefore it is still comfortable to use very high flows with high flow nasal cannula. The other additional advantage is the removal of carbon dioxide. It's because it's going to flush with this higher flow rate. Patient is not taking 50 liters or 60 liters per minute all the time. It's only a fraction of time. So over the rest of the time, patient will have very high flow, continuously flow into the nasal cavity and the pharynx. Therefore, it's going to wash out your carbon dioxide. So it will remove carbon dioxide to a certain extent. So it's helpful other than giving 100% oxygen or high concentration of oxygen, also to give a little bit of PEEP and also to remove your carbon dioxide. So I told you the bad effect with the, it's not bad effect, it's a very good tool to use. However, if you just need to increase your oxygen, giving like 90%, 100% oxygen, if you use non-rebreathing mask, you just need 15 liters of oxygen per minute, and you still do the work. But if you need to use high flow nasal cannula with 16 liters per minute, you need a lot of oxygen to use and have the same effect, just to have increased fraction of oxygen inspired. So the oxygen demand is high. So in a setting where you need more oxygen, like in COVID time, it was a reason, one of the reasons why you ran out of oxygen. But it has its own other good effects, so it can be still used if you need to. But if you just need to increase oxygen, you might do the same effect with just non-rebreathing mask. Okay. And also it will not generate that higher peak flows if the patient is severely dyspneic and it's not delivering that amount of oxygen. But sometimes still the non-rebreathing mask will do. As I told, if it is more than the tidal volume of reservoir. The other device, so all the rest except the non-rebreathing mask and the high flow, they are variable performance. So your FiO2 varies depending on the way the patient breathes and the amount of oxygen you deliver. So the Venturi mask is the one you can have a reasonably fixed amount of oxygen delivered to the patient. So this works in the Venturi principle. So what happened, there's oxygen flow, suppose it's like 5 liters of oxygen going through the tubing, and there would be a sudden narrowing of the tube where the same flow has to go now. Therefore, the velocity of the flow has to increase. So if the velocity increases, what happens? There would be drop in the pressure because the velocity and the pressure is constant. So if the pressure drops, according to the pressure drop, there would be entrain of air from the outside. So this entrain or mixing of air depends on the flow you give to make the pressure difference and the size of the hole. That's how it has a fixed amount of oxygen combined with the air and make a fixed concentration of gases delivered to the patient. Either it's 20%, 24% or 60% or 40%. So if you look at it, even if you use 3 liters of oxygen through the Venturi mask, if you look at this row, you see you will have to deliver the patient 78% liters per minute or more than 40 liters per minute. In a normally breathing patient who has the peak inspiratory flow of 40 around, so all the flow even 60, you need higher flows like 15 liters of oxygen through this Venturi cannula to have 60% of oxygen. And still it is like 40 liters of peak flow, the total volume. Use the Hudson mask where you don't need to give fixed like 60%. If you need to just give 60%, you need 15 liters with Venturi mask it's a waste. If you compare with the Hudson mask, if you give like 10 liters, you will still have around 60% of oxygen. So still you can use 60% of Venturi, but it's not a must. If you need to give 60%, you can just switch to Hudson mask with lower amount of oxygen, right? So now, how you should decide on the device you use. One, depends on what your aim is, whether you just need to give some oxygen to increase the saturation or the partial pressure, or else do you need to give some pressure, the peak pressure, PEEP, that means positive end expiratory pressure, to prevent alveoli collapsing during expiration generally. So in that instances you might need to use other devices. So all the devices I spoke will not have PEEP effect except the high flow nasal cannula. If you need to give a PEEP effect, you need to go for high flow, or else you need to give a CPAP, or else you need to intubate and give invasive ventilation. Right. And the second thing is whether how the patient breathes, the patient's peak flow. So if you need to give high amount of oxygen, you have to always think, we can't measure it generally, but what we can do is we can just observe how the patient is breathing, whether the patient take very rapid large breaths where the peak flows are very high. You just need to think whether my oxygen device is actually delivering the amount I want. If you need to give more, you have to tally with the peak flow or use a reservoir bag. And then what concentration oxygen do we need to give? We'll discuss it later. And then obviously it all matters, the cost. So you need to think if you need to give oxygen for a period of time, whether this is really cost effective, or can we do the same with a lesser amount of oxygen. And then the location, obviously in the ward setup we can use all the like high flow non-rebreathing mask, Hudson mask and the cannula. But if you need more support for other reasons, you will need to go for NIV, that is CPAP or BiPAP, different entities, and the intubation, which is only do in specialized or the places where this, they are experienced or capable to handle. So now, I told this hypoxia, that's why we need to give oxygen. But if you continue to give higher amount, for example, if you think you give high amount of oxygen for the initial period, but then you need to tail down your oxygen depending on the patient requirement. So that is because if you give high amount of oxygen, as I told earlier, that's going to be harmful. So every cell, when they have oxygen delivered to the tissues, it goes in the electron chain, and some will be taken to get energy and convert into water, but at the same time some amount will go into the pathway which causes reactive oxygen species, something like superoxide, peroxides, hydrogen peroxide. So they are reactive oxygen. So this reactive oxygen always build up. So this is taken out or neutralized from the glutathione system or other antioxidant mechanisms. But suppose this oxygen drive to the cell is quite high, so it cannot handle by the normal antioxidant system in the body. There would be more and more reactive oxygen or reactive oxygen species. So that is going to damage almost every cell. So if you look at the sum of the effects, if you consider the lung, which has the highest amount of oxygen when you give external oxygen, it will cause inflammatory lung injury, if you quite similar to ARDS, acute lung injury, and also it will cause absorption atelectasis and also tracheobronchitis. So if you expose the patient unnecessarily to high amount of oxygen at the tissue levels, it's going to damage the cells. On the other hand, if you have higher amount of oxygen in the blood for a longer period, that's going to have vasoconstriction. So do you think that you are going to deliver high amount of oxygen to the cells? As in the body, it has its own mechanism to vasoconstrict and reduce the delivery of this high amount of oxygen to the tissues. So it's going to vasoconstrict and cause its own other effects. And the eye retinopathy, and just because it's going to vasoconstrict, it's going to increases the infarct size in acute myocardial infarction. Right. So now, how do you decide how much oxygen you're going to give to the patient? So in all acutely unwell patients, or in all medical emergencies, you just focus on delivering oxygen until you sort out and the acute condition and come to a diagnosis and start definitive treatment. For that, you need to start with 15 liters of non-rebreathing mask because you're going to give higher amount of oxygen for the patient for a short period. And once this is sorted, then you have to target your oxygen level depending on the situation. So most patients, you just need to have oxygen saturation of 94 to 98%, which is more than enough. And for the same condition, if you need to give oxygen for patients who are with the risk of hypercapnia, for example, like severe obesity, BMI of more than 40, or else like patients who are with COPD with hypercapnia, where the patients have respiratory drive with the hypoxia, you need to limit oxygen to prevent apneic episodes. So you target lesser to 88 to 92. You don't need to give oxygen if the patient having saturation around this amount. In ARDS, your target is lesser. That is because your lung is damaged. You just need to give oxygen to the tissues, which is just sufficient to survive without damaging your lung. So the aim is to just give some oxygen without damaging your lung. So once the acute problem is sorted, your lung will recover and get back to the normal function. So giving more oxygen will be harmful, giving more pressure with the ventilation or volumes, they are all going to stress your lung and cause release of inflammatory markers. You're going to damage your lung more. That's why you target lesser, so you are going to cause lesser harm to your lung by unnecessary oxygen and ventilatory strategies. In acute MI, what happened? You need to give oxygen that is need to be delivered to the heart muscle. However, if you give too much oxygen, there would be vasospasm because it's high amount of oxygen can cause vasoconstriction. So you will have a larger infarct. So you just need to have the saturation target just more than 90, which is enough. You don't need to give extra oxygen if the saturation is above 90. This is same for the stroke. You just need to keep more than 95% of oxygen. This is post-ROSC, that is after cardiac arrest, successful return of spontaneous circulation. What happened? There's a time period where there was no flow. The cells have suffered hypoxic injury. And now you have restored the circulation and the cells will have more oxygen delivered. If you give more oxygen than what is needed, it's going to have more damage in these already damaged cells. So you just need to have oxygen saturation of 94 to 98, not just 100. That is enough for this patient because hyperoxia is very bad for the post-ROSC patients. The last, it's a very rare instance you won't see. These patients who had a chemotherapy like bleomycin, they have lifelong risk of oxygen-related fibrosis. Therefore, if the patient has bleomycin-related fibrosis, at any point if the patient admitted to the hospital, if the patient has had bleomycin in the life, these are usually given for germ cell tumors. So you should always target lower saturation like 85. You should never give oxygen if it is more than 85 because oxygen, it will exacerbate pulmonary fibrosis for those patients throughout the lifespan. Right. So we give oxygen for hypoxia, but there are instances even without hypoxia you have to give supplementary oxygen because it's benefited in pneumothorax to reduce the size and it absorbs the pneumothorax. Carbon monoxide poisoning, that is also because it reduces the half-life of carbon monoxide, so it will have lesser effect. And decompression sickness to reduce the nitrogen, and the cluster headache, which has some proven benefits. So in summary, so always consider oxygen as a drug. You prescribe oxygen, you have to give the duration and the rate, and you have to come down with oxygen whenever you have time. So all medical emergencies or critically unwell patients, you are not going to give 2 liters or just 5 liters or 10 liters. You have to put on 15 liters with 100% oxygen unless you know the patient having COPD like hypercapnic state. And if you need to deliver higher amount of oxygen in the ward setting, you have to consider about the patient's breathing pattern always. That's what you generally think, how the patient breathes, how much the patient takes as the peak flow, and the device you're going to use, whether this device is going to match your need. And it's your duty to daily assess and titrate oxygen and reduce or increase depending on the patient need according to the targets. Right, these are my references. We have the quiz. Thank you very much. Do you have any questions before we go to the quiz? Or anybody didn't understand? No questions? Okay. Thank you very much.
Thank you very much, madam, for that comprehensive and enlightening lecture. I'm sure patient management in times to come. So before we moving on to the next part, I would like to remind you about our blog where you have access to all our lectures, including this one. You are welcome to use the materials and also give feedback about how to improve our sessions in future. So next part is our quiz. So the question will be displayed on the screen before you, and you will be given 45 seconds to answer each and every question. And we expect all your active participation in this part as well. So once the equipment's ID, question will be displayed. program. It is Tarangi Konara, and we are inviting Dr. Punhasi Waduge to present the award. Thank you, madam. To hand over today's token of appreciation for our speaker, I cordially invite Dr. Kanchana Ramanayaka to the stage. With that, we have reached the end of today's session, and I would like to take this moment to thank all those who participate and contributed to make this event a success, especially our speaker, Dr. Punhasi Waduge, and the Branch Union of Government Medical Officers Association, and especially our sponsors, Hema Sidus Pharmaceuticals, for their support. Before we call it a day, I would like to remind you all about our next session. For the next session, we are hoping to welcome Dr. Ruwan Wickramasinghe, the consultant gynecologist of BH Mahiyanganaya, and the session will be held on 23rd of October. And thank you all for your active participation. We hope to see you all in the next session as well, and have a pleasant day.